Welcome everyone to the Neuroblastoma Parent Global Symposium. My name is Donna Ludwinski from Solving Kids Cancer, and I'll be moderating this session. This is on the COG and NANT relapse strategies and trials, presented by Dr. Kelly Goldsmith, who's Associate Professor, Department of Pediatrics at Emory University School of Medicine. Before I hand over, I'd like to draw your attention to the Q&A button at the bottom of the screen to submit questions during the session for her to answer at the end. If the button isn't showing, just hover over it and it'll show up. If you see a question that you like, give it a thumbs up to move it up the list. Over to you, Dr. Goldsmith.
Thank you so much, Donna. Okay. Here we go. Good morning and good afternoon, everybody. As Donna mentioned, I'm Kelly Goldsmith from the Children's Healthcare of Atlanta. And on behalf of the New Approaches to Neuroblastoma Therapy Consortium, or NANT, and the Children's Oncology Group, I am going to talk to you today about current and future strategies in relapsed neuroblastoma. So an overview of the talk today, I will talk a little bit about what relapsed neuroblastoma is and discuss the challenges and strategies for treating recurrent and refractory disease. We'll talk about targeted therapy approaches for relapsed neuroblastoma, as well as immunotherapy approaches. And then we'll conclude and open up for questions. So while outcomes and cures for patients with high-risk neuroblastoma continue to improve, as Daniel was mentioning probably in the talk before mine, about 30 to 40% of patients with high-risk neuroblastoma won't respond to therapy or may become resistant, or their disease may come back. So just to help you with a little bit of the definitions, refractory high-risk neuroblastoma is a tumor that does not respond completely to upfront high-risk induction therapy. So the chemotherapy that you get before you get your autologous stem cell transplants. And relapsed high-risk neuroblastoma is when the patient's tumor grows back in the same or different areas of the body. And this can occur at any time during or after upfront high-risk therapy is completed. So the focus of this talk today is really going to be about high-risk neuroblastoma and refractory or relapsed disease after it comes back from high-risk therapy. So we won't be talking about the localized or non-high-risk disease and when it progresses or it comes back. So what are some of the challenges and how are we going to tackle them from relapse therapy approach? So one of the challenges, as you could expect from a relapsed neuroblastoma, is that they're often very chemotherapy resistant. We give a lot of therapy up front, as you saw Daniel presenting right before this. And so the tumors that survive this are inherently pretty stubborn to respond to typical cytotoxic chemotherapy. So how do we strategize, and what are our opportunities for that? Well, we need to identify tumor-targeted therapies, and that's for a couple of reasons. Along with trying to figure out a different way to treat the tumor that the tumor's never seen before, we also have to be mindful that these patients have seen a lot of therapy that may have caused some toxicities to their organs or to their bone marrow. And so it's really even more important in relapse disease to find therapies that just target the tumor and don't target the normal cells like we experience in high-risk upfront chemotherapy, if we're able to do so. So another challenge in solid tumors, and especially in neuroblastoma, is that it's really what we call a heterogeneous tumor. And what that means is that not all of the cells, even within a single tumor, are the same. Some will harbor ALK mutations and some won't. Some will be more therapy responsive and some won't. And so with these different biologic properties of the cells within a single tumor, it means that we need to have more than one way to target this tumor therapeutically, because it may not all respond to one single therapy. And so that's really why in relapse disease, we focus on combination therapies, such as taking a targeted therapy and combining it with chemotherapy. And we find when you combine chemotherapy with a targeted therapy, patients, even with relapse disease, are more likely to respond again. An opportunity, which is not a challenge, is that neuroblastoma expresses the protein on the cell surface called GD2, which I'm sure you guys have heard about in many talks up into this one. And because of that, we have found that neuroblastoma is probably one of the few solid tumors that is amenable to immunotherapy approaches, such as the anti-GD2 antibodies, 3F8 or dinutuximab, and other ones that have been formed to target that antigen on the tumor cell surface. And so this really has become a focus of not just relapse therapy, but upfront therapy to improve cure rates. So before we get into the therapies, I know you all have probably heard and had some introduction to the Children's Oncology Group from the upfront therapies for high-risk disease. But I wanted to introduce you to the New Approaches to Neuroblastoma Therapy Consortium. So NANT is a clinical trials consortium in North America that's focused solely on developing new treatments and biomarkers for patients with relapsed and refractory high-risk neuroblastoma through early phase 1 and 2 clinical trials. As you can see here, it's made up of a lot of really wonderful institutions throughout the country. And also there are guest sites that are involved in a lot of our clinical trials internationally as well. We also have guest sites that are participating in bringing forward new therapies, and they of course become a treatment site for those trials as well. Now, in talking about what is offered through the Children's Oncology Group in terms of relapsed therapies, there are really two entities, and I'm going to focus on one today and leave the other one for a future talk. Really, for the Children's Oncology Group, when you think about treating relapse disease, you're really thinking about the early phase clinical trials, phase 1 and phase 2 trials. So phase 1 trials actually are focused on understanding the best dose to treat a patient with and defining the safety and toxicity profile of a new agent or new drug in a patient with high-risk neuroblastoma that has recurred. Phase 2 trials are taking it one step forward and treating a patient with the best dose that's been identified and really looking to see if these patients truly respond. And so in the Children's Oncology Group, phase 2 trials for recurrent and refractory neuroblastoma are actually run through the Children's Oncology Group Neuroblastoma Committee, which I am a member of. There's also a pediatric early phase clinical trials network called PEP-CTN, which is really the developmental therapeutics phase 1 trials through the COG that are offered not specifically for neuroblastoma, but for relapsed and refractory tumors as a whole. And so there are opportunities there, but I'm going to focus today on specific neuroblastoma driven clinical trials for recurrent and refractory neuroblastoma through the COG and through NANT. So let's talk about targeted therapy for recurrent neuroblastoma. And when I mention recurrent and relapsed neuroblastoma, I'm actually talking about refractory as well. So I apologize for not mentioning refractory. All of these trials are available for patients whose disease does not respond to upfront high-risk therapy as well. So when we're talking about targeted therapy, we need to bring in the concept of precision medicine or personalized medicine so that you understand it a little bit better. And so the 3 basic steps in genomic-driven cancer precision medicine is that we identify tumor genetic alterations with next-generation sequencing of a piece of tumor by looking at their DNA and RNA. We get that genetic information and we filter that data through a knowledge base of existing and emerging anti-cancer targeted agents. So we find out those mutations and then we look through lots of databases and find if there are drugs targeting those mutations. And then the personalized part of it is that this information is used to facilitate treatment selection by providing a clear and concise actionable genomic and tumor microenvironment report. I apologize for the abbreviation. And by providing a list of potential trials or potential drugs that a physician and the family and patient have choices and can make the best informed decision based on how that patient's doing right now and what therapy they've already seen. And so is this applicable to neuroblastoma when it recurs? So I'm going to take a step back, and I'm not going to get too detailed on the biology here, but I think it's important to know that at diagnosis, high-risk neuroblastoma tumors don't have a lot of genetic alterations or mutations. You guys have heard about probably MYC amplification, which actually is used to diagnose high-risk disease in some instances. But other than that and ALK, there's not a lot of other tumor-specific mutations. However, some pretty impressive research by a lot of researchers throughout the world identified that relapsed neuroblastoma tumors actually have a lot more targetable genetic alterations compared to those at diagnosis when they looked at samples that were paired of a patient's diagnosis and relapsed tumor. And how is this important? Well, what it tells us is if you have an ALK mutation identified, that you may be amenable to treatment with an ALK inhibitor. And if you have a RAS or a MAPK pathway alteration, your tumor might actually respond to a MEK inhibitor. And that's why we believe that there's a role for precision type approaches in relapsed neuroblastoma. So through the NANT, Shahab Asgharzadeh and I proposed a neuroblastoma precision trial called NANT 1501. We really wanted to further define the genetic landscape of relapsed neuroblastoma tumors, and specifically asking these questions. Can we biopsy a tumor, bone, and bone marrow for genetic sequencing? I want to bring it back here that the diagnostic tumors don't tell us what's happening at relapse. And so we're really having to shift the paradigm to actually going back in and relapsing bone lesions or bone marrow or even soft tissue, meaning tumor tissue, to really know what's truly happening at the genetic mutation profile at relapse. We wanted to understand what are the common genetic mutations found. And we also wanted to understand common immune alterations in the tumor and will those affect response to immunotherapy. Shahab's lab also is evaluating whether we can isolate small numbers of neuroblastoma cells in the bone marrow of patients and use those small amounts of tumor cells for tumor sequencing, which would really open up the opportunities for more patients to be sequenced. So what do we do with those results? So reports of the genetic and immunologic changes are provided back to the patient, as you can see here. And the reports provide information about clinical trials available that may match certain genetic or immunologic changes in the patient's tumor. Importantly, no therapy is provided on this trial. This is just more of an information to provide for helping with clinical decision making for the physician and for the patient. And this trial recently closed to enrollment and results will be coming soon. We hope to publish this in 2021. But early results truly have told us that it is feasible to obtain good quality genetic material from bone biopsies, from bone marrow, soft tissue, with limited side effects of those procedures, either from a new biopsy or even from banked or archived relapse tissue for tumor sequencing. So what do we do with that information when we get it? This gives us a lot of information, but are there opportunities out there for patients to get precision-like trials? And so I know Dr. Mose talked to you about this yesterday, so I won't go into too many of the same details. But she discovered that the anaplastic lymphoma kinase gene is the most common neuroblastoma-specific cancer-causing mutation, second alone to MYC amplification, both in upfront newly diagnosed patients, as well as patients with relapse disease. What we have realized is while there's 15% of ALK mutations at relapse in neuroblastoma patients at diagnosis, there's actually 30% or more of patients with relapse disease that have ALK mutations. So this is a huge opportunity to offer a targeted therapy for patients both at diagnosis and at relapse. But the one thing that we've discovered throughout the years, and as Dr. Mose has been performing different phase 1 and phase 2 trials and preclinical investigations, is that the neuroblastoma specific ALK mutations are actually pretty resistant to first generation ALK inhibitors like crizotinib or ceritinib. And so she identified lorlatinib along with Pfizer, and in collaboration, we have opened a phase 1 trial studying lorlatinib in patients with refractory and relapsed ALK-driven neuroblastoma. So lorlatinib is a next generation potent ALK inhibitor. It actually targets the neuroblastoma-specific ALK mutations. Importantly, it crosses the blood-brain barrier. And this is important because we're finding that while rare, more patients at relapse have actual brain metastases. And so we want our therapies to get at everywhere the disease can go. It actually targets crizotinib-resistant ALK mutations, both in lung cancer and in neuroblastoma. And Dr. Mose recently discovered that along with just ALK mutations, patients with neuroblastomas with ALK amplification also are very sensitive to this therapy. And so right now, we are currently conducting this trial. The single agent lorlatinib dose finding has been identified for patients greater than 18 years of age and has been found to be both safe and tolerable in patients of all ages. There were no hematologic toxicities, meaning no blood counts were affected, which is very different than crizotinib and gives us opportunities for future combination trials that might not be doable with prior first generation ALK inhibitors. And common toxicities included increased cholesterol, which is very easily managed with a statin agent if necessary. Weight gain, and this is actually due to increased appetite through pathways that are affected by the lorlatinib drug. Occasionally increased liver enzymes, but all of these are very easy to control and do not limit the ability to continue giving lorlatinib. In the rare instances, because of the blood-brain barrier penetration of this very potent agent, both in adults and in young adolescents and adults with neuroblastoma, there have been some neuropsychiatric side effects, specifically working memory impairment, mild cognitive changes, some psychiatric changes in patients that are predisposed to psychiatric diseases that actually improve with dose hold or dose reduction. It's important to note that this only occurred in our trial in patients greater than 18 years of age, with very limited grade 1 toxicities in patients younger than 18 years of age. And we did very comprehensive neuropsychiatric testing to ensure that our patients were safe from this agent. And as we move it up front to patients with newly diagnosed disease, we're going to continue to monitor that closely, even though we didn't see any indication of patients less than 18 having any of the CNS effects. Importantly, weight gain and increased blood sugars that we've seen with lorlatinib, which seems to be the most common toxicity, can be controlled with diet and exercise alone. So I want to stress that patients that are on this agent, both on study and occasionally off, we recommend patients go on study for this because we have such good monitoring plans for a lot of this, that we recommend do not use an appetite suppressant to prevent the weight gain from appetite, because this drug crosses the blood-brain barrier, and appetite suppressants also have CNS toxicities. So we stress that with any physician using this agent for their patients. I think importantly, and I believe Dr. Mose showed this, that we've seen some very impressive responses, and really for the first time, complete tumor responses, just a single agent that targets a genetic alteration in neuroblastoma at all dose levels in ALK inhibitor pretreated patients as well. So we're very enthusiastic about this agent, and the chemotherapy combination with lorlatinib and topotecan and cyclophosphamide is currently enrolling. So through the COG, there's also an opportunity for a match trial to perform tumor genetic sequencing as well as identify specific agents. And as you can see here, tumors are biopsied or archived tissue is used. The tumor is sequenced, and identification of an actionable, meaning a therapeutically targetable mutation, is identified, and patients go on to one of many of the sister trials through the COG. These are all phase 1 to phase 2 trials through the Children's Oncology Group. And I wanted to highlight here that a lot of these trials are hitting alterations that have been identified to drive neuroblastoma and the aggressive nature of neuroblastoma. So the COG match trial, we're very enthusiastic that it gives the opportunity for more access to targeted therapies for patients with relapsed disease. So you may be asking, well, why aren't we targeting MYC-in? I mean, it's amplified in like half of the patients with high-risk disease, and it's a pretty aggressive protein to in and of itself predict high-risk disease. So it would be really great if we had a MYC inhibitor, but those just don't exist. MYC-in is just not druggable in and of itself. However, a lot of really smart researchers have identified that there are other proteins that help stabilize or help MYC-in work that actually are targets of specific targeted therapies. So here is an example of one called Aurora A kinase. And Aurora A kinase, as you can see here, is really stabilizing the MYC-in protein. And we have Aurora A inhibitors, such as this drug alisertib. And when alisertib goes and inhibits Aurora A, what happens is other proteins are released. They go to label the MYC-in protein. And by doing so, it wakes up the cell to use its mechanisms and machinery to degrade neuroblastoma cells by inhibiting and completely getting rid of MYC. And so this preclinical work, much better than my cartoon, really paved the way for looking at Aurora kinase inhibition in neuroblastoma. So Steve Du Bois performed both a phase 1 and phase 2 study of alisertib, the Aurora A, and it also hits Aurora B kinase in combination with chemotherapy for patients with relapsed and refractory neuroblastoma. The Aurora A kinase inhibitor was given once daily, days 1 to 7, with irinotecan given days 1 through 5. And what they found in the phase 1 study was that this combination was safe and tolerable, and they seemed to be seeing some promising responses. This led to the phase 2 trial, where we found that alisertib in combination with irinotecan and temozolomide improved progression-free survival. And they actually made an oral solution, which made it more available to other patients, younger patients who can't take pills. Interestingly enough, the MYC amplified patients in the phase 2 study did not have as good of a tumor response as the MYC non-amplified for a MYC type targeting agent. And we found that interesting. The one thing that was noted both in the phase 1 and phase 2 trials was that there was significant hematologic toxicity. So blood counts were affected and blood counts stayed down longer. And with these prolonged blood counts, it prolonged the time that you could get the next phase of therapy. And there was some GI toxicity such as nausea, vomiting, and diarrhea. And because of that, we think this was due to the Aurora B inhibition that may have contributed to these off-target toxicities. And unfortunately, because of these toxicities, that's why this drug was only given for 7 days out of a 21-day cycle. And so that insufficient ability to consistently inhibit the Aurora A kinase might have prevented the drug from working as well. And so this led Steve to collaborate with Lilly Pharmaceuticals to propose NANT 1901. This is actually an industry-driven trial that's actually already open at other non-NANT sites. But now NANT is bringing it in for patients with relapsed and refractory neuroblastoma. And it's a select Aurora A kinase known as erbumin. So because it's a select or Aurora A inhibitor with no Aurora B effects, it has less blood counts effects, less heme toxicity. It's again an oral agent that can be given every day of the cycle. There's more on target effects, and it allows for the continuous inhibition of Aurora A. And so we have a phase 1 study that's open or opening at many NANT sites that's evaluating this drug, erbumin, both alone to identify the best dose and safety, and as well in combination with chemotherapy such as irinotecan and temozolomide. So moving on, let's talk about immunotherapies for relapsed and refractory neuroblastoma. This is a very busy slide, and I know you guys are probably experts with GD2 focusing immunotherapy approaches, so I won't go into too much detail. But I think it's important to know that neuroblastoma is one of the few solid tumors that's proven sensitive to immunotherapy approaches through antibody targeting of the cell surface antigen GD2. When given upfront in maintenance therapy, it improves survival by 20%, which led to the FDA approval of dinutuximab for the treatment of neuroblastoma. But I wanted to draw your attention to a hallmark phase 2 trial through the Neuroblastoma Committee of the COG that showed that it was a randomized trial giving irinotecan and temozolomide in combination with temsirolimus, which is an mTOR inhibitor, or dinutuximab. And what they found was probably some of the most impressive response rates in a relapsed or refractory patient. That dinutuximab arm actually had a 47% response rate. So if you don't know, that's a pretty good home run for relapsed and refractory neuroblastoma. And importantly, we saw complete tumor regression in patients with refractory disease and in patients with bulky metastatic disease, which we didn't see when dinutuximab is given alone with retinoic acid in post-consolidation therapy. And so we were very excited about this combination of dinutuximab chemoimmunotherapy. And moving forward with new trials for relapsed disease, we wanted to see if we could improve on the success of this regimen. So I think Dr. Osterhout's going to give a talk on DFMO later, so I thought his talk was going before mine, so I apologize for being abbreviated on giving a lot of information, but many of you may have heard of the drug called DFMO or eflornithine. So this is all based on the premise that MYC increases the expression of an enzyme called ODC1. And ODC1 helps make these polyamines, which are really the building block of proteins in tumor cells. And so we have a drug called DFMO that when we give it, it inhibits ODC1 and actually kills neuroblastoma cells. My former mentor, Mike Hogarty, did some beautiful laboratory work that showed that DFMO in combination with chemotherapy can prevent the development of neuroblastoma in neuroblastoma mice, and also can treat neuroblastomas and cause tumor regression in MYC-driven transgenic mice. This led to him leading a phase 1 trial through the NANT called NANT 1201 of DFMO in combination with topotecan and cyclophosphamide. What they have found is that that combination was safe, tolerable, and had responses. And that data will soon be published. So this led us to wonder if it works with chemotherapy, could we use DFMO with dinutuximab with chemotherapy? So what you might not know about DFMO, and this is preclinical work done by Hamid Basiri and Mike Hogarty in their lab, and this is actually a lot of researchers and other cancers have already shown this, but what you might not know is that ODC1 actually by increasing polyamine synthesis causes an increase in the amino acid known as arginine. And arginine I kind of think of as like a bully. It just suppresses the patient's immune system. T cells, NK cells, these really good immune cells that are actually needed for dinutuximab antibody therapy to work are just suppressed by arginine. And so it's been shown in other tumor models that when you give DFMO, and let me show you here, that ODC1 is inhibited, arginine's inhibited, and actually you have activation and just resurgence of an innate immune activation response of your cells that are important for dinutuximab response. And so this led me and Meg Macy to propose a randomized phase 2 study of dinutuximab, irinotecan, and temozolomide with or without DFMO in patients with relapsed refractory neuroblastoma, known as AMBL 1821 through the Children's Oncology Group. AMBL 1821 is open and enrolling at the majority of COG institutions. What I didn't mention was that phase 2 trials through the COG are not limited to phase 1 sites, which are only very minimal. So for phase 2 studies, the majority of them can be open anywhere at a Children's Oncology Group institution throughout the country. So it really opens up the opportunity for a patient to get relapsed care locally and not have to go elsewhere where they often will have to do for phase 1 trials through the NANT or through the COG PEP CTN. And so Meg and I have the question of, does DFMO improve dinutuximab response through inhibiting polyamines and releasing these important immune cells that help dinutuximab work? DFMO is given daily for 28 days. It's an oral medication that's very well tolerated. And Dr. Osterhout will talk to you about that in his follow-up talk about their trials. And we're giving a 1-week break because we give high-dose DFMO, and this is to prevent any toxicities. You need a 1-week break. And irinotecan and temozolomide are given days 1 through 5. So patient samples, importantly, are being tested for immune cell subset changes over the course of therapy to really see what DFMO does to patients' innate immune system. And we're also evaluating bone marrow and blood for tumor GD2 expression. And this is very important because I think the one thing that is lacking in all of our studies right now is a good biomarker of dinutuximab response, which may have been a question that's in your mind right now. And so we'd like to know that, and we'd like to evaluate it in the most non-invasive way. In addition to waking up the patient's immune system, what if we took that immune system out, activated, increased the number of immune cells, and give them back in combination with dinutuximab? And that's exactly what NANT 1301 trial is doing. It's a phase 1 dose escalation study of autologous, meaning the patient's own natural killer or NK cells for the immunotherapy of relapsed refractory neuroblastoma that's given with dinutuximab and lenalidomide. Lenalidomide is a drug that helps augment those cells in the body. So NK cells are a subset of immune cells that can kill tumor cells even by themselves, but they're only present in very, very small numbers in the patient blood. So Dean Lee at Nationwide Children's has a mechanism of taking those immune cells outside of the body, putting them in culture and growing them up in happy little hormones or cytokines that not only increases the number, but increases their activation to respond to antibody therapy like dinutuximab. Nothing is genetically engineered in these cells. They're so smart that they can do their killing without having to be programmed to recognize where to go. And so when we give back those NK cells, our question is, can that help dinutuximab response more than giving something like leukine or GM-CSF or IL-2 that's trying to do the same job, but trying to do it in the patient's body? And so laboratory experiments have shown that the combination of NK cells and dinutuximab, including lenalidomide, may work better than NK cells and dinutuximab alone. And lenalidomide will be added to the regimen. And Araz Marashelian is the chair of this trial. She's the medical director of NANT. So I can't leave a relapsed and refractory neuroblastoma talk without talking about MIBG. I'm sure you heard about it from Daniel in the prior study and probably in a lot of other talks, but meta-iatobenzoguanidine, and that's the only time I'm going to say that word, MIBG is radio-labeled with iodine, and it's used to detect neuroblastoma radiologically, as you see here. But when we increase the dose, we can give it as a therapy, as an injected radiotherapy to the patient to get to all the sites of disease. And so MIBG is taken up specifically via a transporter protein that's on the surface of nerve cells. And so that's why we have side effects of pain that we see with MIBG, because sensory fibers also have these transporters. So we know that it's been used by itself since the 1980s, and prior studies have demonstrated a pretty impressive response rate in patients with relapsed refractory disease. And as Daniel mentioned, right now, because it was so effective in relapsed and refractory disease, it's been moved up. So ongoing evaluations by Dr. Du Bois were to see they have run phase 1 trials of all of these combinations. Can we combine things with MIBG to make them better? And so we had a phase 2 study, NANT 1101, that was to look at different regimens, patients randomized to each of these arms of MIBG alone, MIBG with vincristine and irinotecan, which have shown preclinically to take up MIBG better, or MIBG with an oral agent known as Varenastat, which also has been shown to help uptake of neuroblastoma into MIBG into neuroblastoma cells. And the results actually just recently came out and were presented at the American Society of Clinical Oncology meeting, that of all of these 3 combinations, that the most impressive response rates was in the arm where MIBG was given with Varenastat, and it had the association with the highest responses. And what they also noticed was that vincristine and irinotecan, while not increasing response rate, did increase toxicity. And so my final trial that I'll briefly talk about, because I don't want to go over your question period, is if MIBG is good and dinutuximab is great, what if we combine them? And there's actually some preclinical evidence that shows that this actually has precedent and might work. I think you guys have learned about this in the minivan trial, and we're doing something similar throughout NANT, that our trials really came to light at about the same time. And so NANT 1701, that's chaired by Thomas Cash at my institution, the Children's Healthcare of Atlanta, is a phase 1 study of 131I MIBG with dinutuximab for patients with relapsed or refractory neuroblastoma. And we know that radiation upregulates stress antigens on the tumor cell surface that actually help your innate or your own immune cells recognize the tumor better. So if you can get your tumor cells more recognizable, and you can activate your immune cells through this systemic radiation, can we improve responses to the antibody therapy that's going to be covering those tumor cells? So the treatment plan is that patients are admitted for the MIBG therapy. They clear the MIBG therapy so that everything is safe to receive dinutuximab and GM-CSF on day 8. And then they're actually readmitted to the hospital for a second course of dinutuximab. So if any of your children, or if you know of someone whose children or patients have received MIBG, the radiotherapy effect can continue from 6 to 8 weeks. So we're maximizing that effect by giving dinutuximab twice in that single cycle. And so because of Dr. Du Bois' data in the randomized MIBG trial through NANT showing that Varenastat and the MIBG arm are best, and also some data from Robbie Majnar and others at Stanford that showed Varenastat may actually be increasing GD2 on the surface of tumor cells, that we are now expanding our study. We've identified the maximal dose of MIBG to give with dinutuximab. And so we're expanding the study to include Varenastat in the treatment with MIBG and dinutuximab to really maximize the GD2 response and the MIBG response. And we're very excited about this expansion that hopefully will be opening before 2021. So in conclusion, I hope I've really shown you that NANT, first of all, I hope I haven't lost any of you guys. And if I have, I really apologize. But I wanted to get through, and it's a lot to cover. But we really have a lot of trials targeting relapsed and refractory high-risk disease through the NANT and the COG. And what I really want to stress is that every child with relapsed and refractory high-risk neuroblastoma is unique. There's really not one best first choice relapse therapy that you may see with other high-risk cancers that recur. And it's really based on clinical status, tumor genetic alterations that are identified, the availability of treatment slots on a trial, and really prior response and toxicities to upfront therapy that will help your physician and your team and your family understand what's the best therapy for your patient and your child at that time. Many tumor targeting methods to treat neuroblastoma really focus on the relapsed tumor. And as you can see here, I'm not going to go into details. We target ALK, GD2, MICN indirectly. And due to the aggressive nature of relapse disease, the focus on combination therapy is really the best first approach. And I want to say thank you to the organization that created this amazing global symposium, to all of the foundations and sources that support this. And I don't think I've been able to mention them all, but most importantly, I want to thank our patients, because with your participation on these trials, we have truly advanced our understanding and the survival of patients, not just with refractory and relapsed neuroblastoma, but these trials really form the foundation that moves forward to improve cures for patients with newly diagnosed high-risk neuroblastoma. For as you saw, Daniel presented a lot of the same studies and trials that we really start here with these early phase trials to understand what kind of impact we can make on our kids. So I'm happy to take any questions.
Thank you so much, Dr. Goldsmith, for an excellent presentation. And we do have some questions. We have a few minutes to cover those. The first one is fantastic presentation. Are NANT trials available in Europe? Is any kind of collaboration planned, especially for DFMO-based trials or precision match drugs?
Yes. The answer to that is yes. NANT trials, while we don't have a specific NANT site in Europe, we actually are partnering with a lot of institutions. The Institute Curie, the Australia and New Zealand. We also, I apologize, I'm trying to think of all of the sites that we have been working with, but we truly do partner with them right now for our lorlatinib trial, where we've been working internationally, which has really formed the basis for working internationally up front for moving lorlatinib up front to high-risk trials. And so I think that the opportunity to become a guest site for a place that is not as always open for discussion, because we want to make these treatments available. Also through the COG, we're, along with being an international consortium, we specifically have the 1821 trial open in Canada and in Australia and New Zealand, because they actually form the preclinical basis for the studies that we're doing in our patients.
Oh, fantastic. The next one is about DFMO. What do you consider high dose DFMO? How much is actually given?
So we're giving anywhere up to, I think it's like 6 grams per kilo. And I know in some of the maintenance doses and trials that you'll hear about later today, it's not quite that high. But in the Nance study 1201, we found that those doses that were that high are very well tolerated in patients with minimal toxicity. The one thing that we have noted and has been noted prior, this was a drug that was used to treat brain infections known as trypanosomiasis. I can't believe I said that. And so it does cross over the brain, and it actually can particularly affect the cochlea of the ear, but it's been very well known that hearing effects by DFMO are reversible and so that's why we've incorporated a 1-week break into our study in the COG to minimize the likelihood of developing hearing side effects. And with that 1-week break, Dr. Hogarty's trial in Nance showed that there was very minimal hearing loss in that trial.
Excellent. Then the next question is, can different sites of disease be different in terms of their biology, mutations, etc.? For example, primary tumor versus bone marrow.
That is an excellent question. And I think all of the research that's been done really shows it probably is. It really makes it difficult because we can't biopsy every site of the disease. We're hoping that as we advance in detecting circulating tumor DNA, which we're doing as part of our lorlatinib trial, and as we're doing with upfront high-risk trials like 1531 through the COG, that may capture more of the systemic disease that we see at other sites of metastasis because tumor cells are constantly shedding their DNA from all sites into the blood. So along with being less invasive in terms of being able to monitor changes, we may actually be able to capture more changes. And based on the data I've seen through Dr. Mose and my lorlatinib trial, we are truly capturing more alterations than we see just from a single biopsy at a tumor.
Fantastic. This question is closely related. It's wondering about the point of having your original tumor sequenced if it wasn't sequenced at the beginning versus just sequencing the relapsed tumor.
Oh, just asking, so
is there any point to sequencing a primary tumor, at the point of relapse?
No, I don't think so. I think the most important thing that you should take home from the initial high-risk disease is that your tumor at diagnosis, whether you're on study or off, should definitely be tested for ALK alterations. And MICN is always tested anyway as, from our pathologist because it helps identify high-risk disease, but ALK is not always mutated and it's not always tested unless you're on a clinical trial that's looking for that. And our Children's Oncology Group biology trial that you enroll on does not test for ALK. You have to actually be on a clinical trial. So because of that, if your diagnostic tumor was never tested for ALK, and if you have a relapse that's just not accessible by biopsy, and it's just impossible, or you only have a little bit of bone marrow disease, I would say look at your diagnostic tumor for ALK because ALK really drives aggressive disease. And so you may be able to capture ALK alterations. But really, other than that, the relapse tumor is going to give you your best landscape of targets that you could approach when your patient's tumor comes back. And it's really become a clinical practice almost in adult oncology. And really most parents that I deal with, they're like, here, please, let's find out. We need to know. And so it's becoming better. And we have interventional radiologists that are super fantastic and they can go in and get a bone and the patient's up and walking around the next day. So it's actually becoming a little bit easier to get that tissue safely.
Oh, that's great.
Yeah.
Now, the next question is it possible to have MICN amplification at diagnosis and then ATRX mutation at relapse?
Oh, that's a very good question. Usually not. They're very independent of each other. Most, and as I'm sure someone else has mentioned, ATRX mutations are often found in older patients with high-risk neuroblastoma. So oftentimes they're more independent. And as your child grows and gets older, but I never say never because as someone else asked the question, are different sites of disease different? So I don't know the answer 100% to that question, but I would think most of the time it wouldn't be her.
That makes sense. The next question is for relapse neuroblastoma, how important is it that it's found early? Are existing scan intervals sufficient?
I think so. I think that the existing every 3 months after you get off of therapy, unless you're symptomatic, is enough to identify relapse disease. In terms of catching it early versus late, we usually don't approach it any differently. Most of the time, if you have a patient who develops a lot of bone marrow disease at relapse, that may affect the patient's ability to immediately get on a trial that needs certain blood counts, like an ANC at a certain level and a platelet count at a certain level. However, most of us account for the fact that patients with relapsed and refractory disease are going to have bone marrow involvement. So even if, let's say, your child's having pain and you don't catch it and it's in the bone marrow now, there should still be availability of studies. So I don't think that testing any sooner is going to change the management. And most patients are asymptomatic when they recur. So it's often captured on those scans.
Excellent. Well, thank you so much, Dr. Goldsmith. We are out of time, unfortunately. We do have a few unanswered questions, which we'll try to follow up with you later. Please follow up with the next sessions: neuroblastoma drug development strategy, new therapeutic targets and strategies, and low and intermediate risk neuroblastoma. Head over to the Watch Live page in the event website to start viewing. And don't forget, you can see this on demand after the session is done. Thank you again, Dr. Goldsmith.
Thank you so much. Thank you, everyone.